Okay, so I'm just going to introduce Dr. Nick Waldron. He's just going to talk about falls prevention in WA, why are we successful, and where are the gaps in research. So thank you.
Thank you, Sue, and thanks for you guys for coming along. And to all the guys on the WAX sites there. This is actually, Sue asked me to give the presentations we gave at the Grassroots conference. So probably a lot of people may have seen it already. So what I've done is merge two of them together. So what took an hour and a quarter, hopefully we can do in about half an hour. So I'll either talk very fast or I'll skip bits out. I'm not sure which way it's going to go. But the first part of it is really just before I start creating the crisis, where we all get worried, you know, where are we going with inpatient falls prevention? Because we are actually in a really interesting time where we're about to see significant changes to guideline recommendations of which represent the care that we currently give. So we'll talk more about that. But before we get into the doom and gloom, I thought we would focus a bit on WA and falls prevention. So it's always nice to talking to just people in Western Australia because I can be very parochial, and even though I'm from New Zealand, I'm very proud of Western Australia. So how do we measure falls? Basically, nationally, they do this by looking at hospitalisations related to falls. So anyone who's involved with service development will be aware the first thing that people want to go talk about is reducing admissions to hospital, reducing length of stay, reducing costs. So that is the kind of key thing that healthcare or health service people tend to focus on. They do this across Australia for falls.
Hi, it's Kalgoorlie here.
Oh, g'day.
We can't hear you. We're supposed to be hearing.
Oh, okay, yeah. I'm not sure about that. Is that better? Or is it completely muted? Kalgoorlie, can you hear us? That doesn't sound promising. We can't hear you if you can hear us, but that's probably okay.
Hello, we can't hear you.
Can anyone
Well,
hear
luckily
us?
I have my beautiful assistant here, Sue, who can sort this out. Sue.
Beautiful, definitely not. Can anybody hear us?
Northern can hear you.
Great.
Someone can hear you.
Awesome. So,
can hear you.
all right, Kalgoorlie, I think it's your problem. Sorry.
Maybe it's on mute or something like that. Having a look at the sound and see if it can turn it up.
Give your telehealth a call. They'll be able to sort it.
Do you need paper to write a message? Call your people. Sign it.
Okay, well, I'll keep going then. So in Australia they do this using data, which is collected routinely by all states. And in 2008, 2009, the publication came a couple of years later, like they all do. And what we see is quite a bad story actually for falls. Despite all the effort, all the focus, all the research, we're actually looking at an increasing rate of falls admission, so age adjusted. So the situation for falls is getting worse across the country. But when you look at it, there's actually a bit of variation between states. So this is another publication which looked in 2008 to 2009. And you might see there's the confidence intervals, which is that kind of, sorry, I'm just trying to get the line here. The confidence interval, which is this kind of inverted or sideways H shape, is below the bold horizontal line. So what that means is that there's a statistically significant difference in South Australia, Tasmania and Western Australia. So there was variation between the states, so not every state is performing the same. Okay, and Western Australia is the biggest of those other states. The other ones are quite small, so the actual the meaning of that is less. Whereas for WA we're bigger, so it's meaningful. So, and when we look at the trend, we're seeing again that this trend has been bucked. And in Western Australia, the figure is that they were stable. Okay, so when we look at the first graph, but we look at per state, we see a stable pattern. So I've given that big blue arrow to point out where WA's data. So we're not increasing in Western Australia by 1.5% per annum. In Western Australia we are flatlining according to the national data. So that may not be, at least it's staying the same, not getting worse. so just to point that out, that we're actually bucking the national trend. So I think that's something we can be proud of, and probably is a reflection of the kind of cohesive nature of how we've approached falls for well over a decade. If we look at this document, which is released by Western Australia, which looks exactly the same data but a bit more sophisticated way, with the epidemiology department, what we see that when we break it down by sex, for females we're actually reducing falls prevention, falls hospitalisations. For males it's stable. Okay, so we're actually getting a reduction in females in Western Australia if you look at the detail. So that's good news. So yay, go WA. Hip fractures across Australia are reducing, okay, and this is seen in every state. But again, here's that graph again that looked at the year's worth of data. Western Australia seems to be performing at a higher rate, so its hip fractures are reducing at a faster rate than other states. When we look at Indigenous patients, however, that it's not such a positive picture, and this again is some WA-based data using using the kind of data linkage, and what it shows is that Western Australia Aboriginals are increasing their rate by 7% per annum. So we're actually got a widening gap situation, not a narrowing gap. What's interesting about this data is that the way that we're falling seems to be changing. So we're getting less upper limb fractures, but more other fractures. So, and more brain injuries. So we're hitting our heads more often, but breaking less hips, if that makes sense. And the rates of dying are still increasing. Okay, so there's some positive news. Western Australia's doing quite well at the main indicator, and it's outperforming the other states. So we're going to move to hospital falls prevention. Are we in crisis? Is there a solution? Which is actually the title of the talk that Sue promoted. So we're going to talk a little bit about falls in the inpatient setting. I mean, I'm aware that people have heard so much about falls in the last month or two that you already know a lot. Talk a bit about the crisis. So what I'll be presenting is called the Six-Pack Trial. This is the largest ever falls prevention trial, and it hasn't been published yet. So we're kind of, we like to keep ahead of the wave in Western Australia and know about these things before they happen to see whether we actually need to change the way we're doing things. So I'll create the crisis, and then we'll talk about the solution. And that's the, you know, kind of, we can all sing Kumbaya and say, gee, we're doing a great job as clinicians, and it's a happy ending. So don't be too distressed, but I'll try and make you distressed during it. Okay, so we know falls are different in hospital, say, to the community setting, and, you know, for clinicians, this is, we know this. They're more common, there's different risk factors. Typically, they might be unwell, there's a loss of locus of control, they're more dependent on other people, physical dependency, there's a loss of their routines, they don't know how hospitals work. And then they change, they get better, they get worse, it fluctuates. And so it takes a bit of time for the nursing staff and the medical staff and allied health staff to understand the patient, and for the patient to understand the staff and the environment. But often people fall before they really understand that. So looking at it in a different way, so we're kind of going out of the traditional inpatient falls stuff. Now we're going to talk about geriatric syndromes, of which fall is a syndrome. So we're taking a move away and just talking about how does a geriatrician or how do those involved with comprehensive geriatric assessment approach kind of illness in older people. And so this is the concept of the geriatric syndrome. So the nursing staff can do this, allied health staff are always part of that mixture. And falls and altered cognition are the two common ones. What we know is that, so what we know is that when you have one of these syndromes, there's other ones like pressure sores, incontinence, impaired mobility, iatrogenesis, so when we do harm to our patients. We know that when you have one of these syndromes, you basically have a bad outcome. Increased morbidity, and patients are often a bit neglected because they don't fit into the kind of single organ system approach. So typically we look for organ-based problems in hospitals. Modern health services are devised in that way. The response is typically technically driven and based on single disciplines, usually medical. That's how our normal systems work. That doesn't work for these people because they've got problems which cross across their different organ systems. So typically, let's say someone with pneumonia, this might be what happens. They come in with a cough, sputum, a bit of shortness of breath. You know, the nursing staff do their OBS and ED and they've got a fever. some blood tests are ordered, they have a raised white cell count, a chest x-ray confirms infiltration. Boom, we've got a diagnosis of pneumonia. It's not particularly hard, is it? Then you look up a guideline and it tells you what antibiotics to give. You give them a bit of oxygen, make sure they can drink and fluids, and give them Clexane, and then you admit them to hospital. It's pretty simple medicine when you boil it down for a lot of what we do. And then they recover and get better, and it's a rosy story. Okay, so that's a typical presentation, and we're very good at doing this. What happens with older people with geriatric syndromes, and the people that fall in hospitals as well, they don't present with that nice package of symptoms and signs. So they might present with delirium, confusion, off legs, a fall. And then when you do those tests, you don't find anything, except when you do a chest x-ray, you find out they've got pneumonia, but they've got no other symptoms. No fever, their CRP's fine, they don't look short of breath, their saturations are fine. But nevertheless, the diagnosis is still the same. Again, you give them the same treatment, but instead of getting better, they get agitated, they get benzodiazepines. Okay, and then it gets more complicated. But don't worry, this is why we work in teams, is because you find out that actually things weren't that good at home. They're socially isolated, they've been inactive, they had malnutrition, they've been constipated, developed urinary retention, needed a catheter, got restrained, and then they're on a heap of drugs they didn't need to be, so they get low blood pressure, and then all of this results in a fall. Okay, so I'm just building the complexity. It's not that we need to know the detail, but it just really validates why we approach things in the way we do with the FRAM. Okay, inpatient falls is not just that kind of approach that we do as care providers. It's also about the environment around us. It's about the decisions staff make. It's about their knowledge, which is why this education that Sue's giving is so important. It's about the ward culture and safety culture. It's about whether there's kind of available environmental and equipment support. And we'll talk about low beds, and we'll talk about bed alarms, because they don't work. All right? The evidence suggests that these things do not work.
Don't say that.
I'm doing a bit of a pause for dramatic play. But that's what the evidence says. So if you go to a researcher, they'll say they don't work. Okay, who uses them?
We do.
I'm sure there's people that
Is it as a
use them.
single intervention though? If it's...
Yeah, we'll talk about it. We'll go into that. So, all right. So as we know evidence, what we do is go through this kind of enormous production of literature, and we then try and we filter it through things like meta-analysis, and eventually we produce guidelines. So there's an enormous amount of falls research, but what we're focusing on today are the gold bars. So through that whole process, you get it distilled out into the kind of big ticket items, okay? And for, that's reminding me to breathe. I did have a video, but I can't show you that, so sorry about that. What we end up with is the evidence suggesting that multifactorial intervention is effective, okay? And you might notice down there, this is the 2014 Falls model of care. It's got the patient education, which was Anne-Marie's work. Now that will definitely go up to 2, probably 3 bars next edition, because of the trial that will be published in the Lancet on Friday. So we will, through Sue's network, we will send a link of the media release and some information about this, a short video about this publication, because it's actually a massive thing for Western Australia. To have something that's in the Lancet is really big. So Anne-Marie Hill's done an amazing job, and all of those people across the metro sites, across the community practice, have helped support that. Really should be feel proud of being part of that. But we're not talking about education today. We're talking about the other gold bars of multifactorial assessment and intervention. So in WA, we use the FRAMP to implement this evidence. Okay, and when we think about the FRAMP, it has things about medication. So the person that had postural hypotension and fell over, we've got interventions for medication. The toileting problem with fecal impaction in the catheter. On the FRAMP, we've got a continence plan and how to address and identify these things. And then, of course, we've got mobility as well as cognition. So all of these things get addressed in the FRAMP, and then different team members give treatments within their specialties to try and make the patient better. And that's actually how comprehensive geriatric assessment works too. So that's exactly what we do in rehabilitation and aged care units. We work together cohesively around the patient's problems, all giving treatments.
Attention, attention please. Code blue, ward G62. Code blue, ward G62.
So, okay, so let's look at the evidence for this multifactorial intervention approach. In the Cochrane in 2010, so that's in terms of our picture of Kalgoorlie in the super pit, this is the process that occurs to get that gold out. So Cochrane produced these lovely documents, usually which say we're unable to make a conclusion, more research is needed, but in the case of inpatient falls prevention, did conclude that these interventions appear to be effective in reducing the rate of falls. Okay, and note there's only 3 trials there. 3 trials. What Cochrane starts talking about is that it seems to be the longer you're in hospital, the more you benefit. That it's not a one-size-fits-all, so all the trials were different. And they don't really know of the interventions we do, which of those things that we do, so that could include, you know, bed alarms, low beds, kind of fall alerts, bracelets, education, physiotherapy, all of that kind of stuff. Which ones of those interventions are the effective ones and which ones aren't? So we don't know the answer because it's not been really looked at. So Terry Haynes and myself tried to look at this, and admittedly Terry did all the work and I was just kind of trying to keep it so it was reasonably understandable. And so what I said to Terry then was, so for Terry Haynes, he works with Anne-Marie Hill, was what we really want to know is what is it we should be doing as clinicians? You know, what is that single thing that we could do that will make the biggest difference for our patients? And so, but Terry said to me, look, I can't give you the fish, but we're just teaching you how to fish. So this is a fishing expedition of which we end up hungry because we don't get the answer. Okay, so it's a little bit dissatisfying, but we do have the answer with Anne-Marie's Hill work. The single thing we can do is patient education using a trained educator on rehabilitation wards. And that will reduce 40% of falls on top of doing FRAM. So we actually do have the fish now. But we're talking about multifactorial intervention. So we looked at all the different types of things that they did and the number of trials that were successful, and it's really hard to get a pattern of exactly which part of that intervention is effective. Okay, so what kind of happens then is when you start in this kind of complex intervention stuff, so that's what geriatric care is, we start thinking, oh, maybe we're doing too much, you know, and you see this in outpatients because you recommend, like, you know, that they have to do 7 or 8 things, and they're like, what? I can't do 7 or 8 things, I can do maybe 1 or 2. And so when we look at community evidence for falls, sometimes doing just simple things is better than doing complex things. So, for example, exercise and balance programs is a single intervention. If that's all the patient does, is beneficial. An OT home visit, if that's all they do after hospitalisation, that's beneficial. Vitamin D, if they're vitamin D deficient, that's effective. If they're on benzos, getting them off benzos, that's effective. So you don't necessarily need to do, you know, 3, 4, 5 things. You can sometimes do 1. So I guess when the inpatient setting, people started thinking, well, can we just do 1 thing? Okay, so we're going to talk about single interventions. So low beds makes sense from an injury perspective because what we know is that if you fall from a higher, there's good research to back this, but I think, you know, do you really need research to tell you that if you fall from a metre, you hurt your head more than if you fall from 10 centimetres? That's the kind of, but that's been proven. So it makes sense, doesn't it? If you're lower down on the ground, you're going to hurt yourself less than if you're higher up. And, you know, it's a common nursing strategy. In New Zealand, we used to do it by just getting the mattress off the bed and putting it in the corner of the room. That was our low beds. They're probably not allowed to do that anymore because of occupational health and safety. So it's just kind of a sensible thing to do. But unfortunately, when they did this trial across a hospital and compared it to a hospital that didn't have low beds, there was absolutely no difference. So the conclusion from that is that low beds aren't effective for falls prevention. Okay, but we need to be very careful to think, well, what does that actually mean? And what do they actually do? And is that relevant to my patient? Does that mean we get rid of our low beds? And this is where research and even randomised controlled trials like this was, a very well conducted trial, you kind of have to start interpreting it as a clinician, thinking maybe that's really not that helpful. But you also have to be aware, am I just discounting something because I don't like what it's saying? But I think in this case that low beds are definitely not a single ticket item. So it's not like you can go and get low beds and just fill the hospital with them and everything's going to be okay. But what they didn't do in the trial was education on how to use the low beds. They didn't monitor to see if they're used properly. They just basically put a whole heap of beds out there and it didn't work. So I don't think, it's not how we would like, it's not how I'd hope that we introduce low beds, people will start knowing how to use them and check up on it and have policies and procedures around use. So that's low beds. So the evidence says they don't work, but in reality, if we do it properly, they make sense. Bed chair alarms are similar. So for bed chair alarms is basically when you've got, so you can correct me if I'm wrong here, but you have a mat usually on a seat or on a bed, and when the person goes off the mat, the pressure sensors detect that there's been a reduction in pressure, and then that causes an alarm to go off. So then the nursing staff will get a page and they'll be aware, wait a second, that patient should be in their bed, now they're not, I need to go and check up on them. So a way of kind of alerting a nursing staff that the patient's trying to get up when they can't see them. Didn't work. So it had no effect on falls when they did this and distributed them around for use by nursing staff. But when you look at the details of the trial, what actually happened was they just got so many pages that they started ignoring them. Because they were using it not judiciously but liberally. So the nursing staff would be called, maybe 7 or 8 times by the same person in the ward when they're just moving or wiggling around or something. So it ended up being very hard to actually, the staff didn't like it because it just became a burdensome amount of work for them going to these false alarms. So, and since that time things have become a bit more sophisticated. So where's the most up-to-date thing on bed alarms and usage and how to make it more effective? You're probably better at this one than me.
Probably not, because there still isn't very much out there in terms of actual solid research that you can use. Anecdotally, I know that they do work, but the pages don't work because the staff ignore them.
So how do you get around that?
We just have it's a sound, so when they jump off, you hear it outside the room.
Yeah.
And so anybody who's near that area goes in straight away. So it has, we've had a big reduction in falls. I'm not saying it's due to the chair alarms, but I think they've had an impact. Okay,
so that's a very practical thing of adapting to that problem by having a noise go off and then anyone around responding. That makes sense.
And the patient hears the alarm as opposed to
They do, don't they?
as opposed to the pager, which means you can educate them when you have to reset it, that alarm is their reminder, they're meant to buzz the nurse before they get up.
Okay.
So it's educational as well as the pager system.
Yeah, so that's a very good point, that the patient also gets the feedback that they get the buzzer and then they can be educated and be safe as well. So again, the RCT didn't show it worked, but they didn't do these small things that make such a big difference of clinicians using their expertise. Education we've talked about, which is really the big ticket item in the way for falls. The future of falls lies in, for rehab settings, lies in individualised education. I'll keep repeating that. We've all got to repeat that, by the way. So when this email comes out, I want anyone who's in the community practice to forward it to their managers to say, hey, look, we should be getting this for our hospital. If they've got contacts with the executive, to forward it to them, say we should need to get this in our hospital. We need a kind of ground up swell of people saying, hey, we want this for our patients. This is a trial we did in Western Australia, and we want it done in our hospitals, please. Because otherwise it's going to get ignored. And it's not costly. In the trial, for every $4 invested, for every dollar invested, it saved $4. So in the trial period, it saved $770,000. So it's a cost-effective thing too. It's not just about paying more money; it's about saving money. So make sure you get that message out, please, because we need all the help we can get to try and get this thing to practice. In 2012, getting back to the kind of Kalgoorlie gold pit again, basically they didn't really add much. In fact, there was no real trial since between that time, and so again they're starting to say that we need to confirm the effectiveness. Maybe they're not effective. if anyone's ever looked at a Cochrane review in detail, and I'd recommend that you probably don't, unless you've got a real research bent, but this is the kind of graph you get. So you look at, say, for multifactorial interventions, you can find a graph, and then it will break down the individual trials. So you can see, sorry, there's 4 of them there now. And so one of them is by Terry Haynes. One of them is actually orthogeriatric intervention, so for people with neck and femur fractures, and that's why Charlie Gardner's has the NOF unit. And that's very evidence-based care and very effective care. So that trial is there as well. So it's kind of a bunch of different trials. And then you end up with that diamond, which almost hits that vertical line this time. So this is in the middle of the rate ratio. So what that means is that it is, when you add all of these trials together, it is statistically significant because it doesn't cross that midline. Okay, but it's really, really close, worryingly close. This is kind of the level that I come to statistics with, is like, that's less than a millimetre, that's close. But if it's miles away from it, you think, oh, well, that's actually pretty effective. So it's quite a good visual graph. I actually do quite like it. Okay, now the 6-pack, the mega trial, the trial to trump any other inpatient falls trial. This thing is massive, okay? And I'll give you the numbers soon. It's due to be published. It was done, and what it was based on was this graph here, which showed, and this is similar to, well, in fact I'll show you later on, what it showed that when you did the 6-pack thing in Northern Hospital, over a 10-year period you get a reduction in hospital-related falls injuries. Okay, so they thought, so the researchers thought, Dr. Anna Barker thought, wow, maybe what they're doing is effective in preventing falls, so let's do a trial on it and do a randomised controlled trial and see if it works. Okay, that's the logic behind this. So when you look at the number here, so this is the Cochrane review. So there's, so far for the hospital trials, all of the hospital trials combined, so not just the multifactorial intervention ones, there's 30,000 patients. This single trial has 31,000 patients. So it's got, this single trial is equivalent to all of the other trials added together for inpatient falls prevention in numbers. So it basically replaces the Cochrane in terms of numbers. It's massive. It's enormous. Okay, what is it? What they do is the Stratify tool. So they do an assessment, and then they have 6 nurse-delivered strategies, and the idea is that you get a risk reduction. So this, so this is the kind of paperwork they fill out, and these are the types of interventions. So one of them is you put a fall alert there. Does that sound familiar to people? One of them is that you help them to go to the toilet. One of them is you have low beds available. One of them is that you have bed alarms. One of them is that you have a mobility plan. And the other is that you've got adequate amount of toilet paper. Sorry, I can't remember what that last one was.
Toileting plan.
Toileting plan, and then, but also observing in the toilet, I think. Yeah. So that's what they call a care bundle. So instead of like what we do, which is like choosing with the Frank, we choose from a whole heap of options. This is a bundle saying, okay, here's 6 things you can do. Which ones of them are you going to do? Okay, so this was done across 6 hospitals and 12 wards, controls and intervention. And they basically had a massive team that did it. So they, yeah, sorry, you go.
Is this in the UK?
No, this is in Australia. This is Monash University. So this is in Melbourne. So this is, yeah, so this is Australian data. So it's entirely relevant to us. And it's in the same culture, it's the same settings, and it's done in acute settings. So the average length of stay was about 4 days. So if this had been positive, this would have been massively influential in how we deliver our care. It's been negative. Okay, so all of those things that we're seeing that are usual care didn't work in the setting. Okay, so that's the negative. So that's the bad news. This is the crisis. Is that you've got this mega trial as big as the entire Cochrane, which has been negative, and you've got intervention, multifactorial intervention, of which this is one, which is barely significant. And now, with this trial, the guidelines are going to say that what we do is our baseline care in the FRAM is not evidence-based care. Okay, so this is the looming crisis we face. But don't worry. we can get around it. Okay, so this is what people looked like in the trial. Half of them male, average age is 64, average length of stay about 4 days. So typical kind of general medical ward, really. And what they did achieve was that they did get people having the falls alert sign and at least one other strategy. So that squiggly line going up is over the trial period. So the number of interventions that people had did increase. And most of the graphs look like this. So the dark blue line is the intervention line and the other one's the control line. So the number of strategies given across the whole ward averaged about 200 per occupied bed days, but in the intervention arm it went between it was about 1,000 or 800 to 1,000. So they're getting roughly about 4 times as many of those interventions in the intervention group, if that makes sense. So that's of the care bundle. So they're getting a lot more of that type of stuff. Again, this graph is the same for use of low beds, for the fall sign, for the bathroom supervision, and through the toileting plan, which was documented in the notes. So the interventions did actually happen, because you could say maybe it didn't work because people didn't do any of the care bundle, but they did. The gate was not so successful, so they didn't really actually get the gate aid being reachable. That didn't work. And the alarms didn't really make any difference either. The alarms weren't used at a higher rate than what they were at baseline either. So 2 out of the 6 of the care bundle didn't work. So what are we left with? Low beds, which we've just shown don't work as a single intervention. We're left with bed alarms, which we've just shown don't work as a single intervention. And then we put a card up above their table and show them how to go to the toilet. So it's not that dramatic. But the result is dramatic. So it made absolutely no difference doing that. What they did see that there was a trend towards less specials. So that's one interesting thing, that maybe when you do this type of thing you need less specialing, which is an issue for most hospitals. So why didn't it work? Was it because it was a weak? I think, and I haven't seen anyone yet. I haven't even seen the paper, and we've had some discussion with Terry, who's one of the authors as well. So I think the intervention was weak, wasn't strong enough. You compare it to what Anne-Marie Hill does with the education, that's potent intervention. They only documented bathroom behaviours, so they didn't actually observe them. So they might have written in the notes they're going to do this, but then they actually didn't do it. The nursing staff may not have actually carried out. Walking aid access was poor, and we had just demonstrated that those 2 interventions of low beds and alarms had been shown not to be that powerful, that they were effective in single trials. Was it contamination? Was it a lack of ownership by the ward, which I think is really important? I like in Western Australia how whenever we do anything, we do it from the ground up, and we try and have staff engaged in it. And so I think the lessons we can learn from that are we've just got to be careful about a catchy name. I mean, 6-pack sounds cool, doesn't it? I thought it did anyway. I was like, yeah, we want to do that, without knowing what it was. I think they didn't really do an exploratory trial. They just went straight into this massive RCT. I don't think they clinically engaged people adequately. There's nothing about the patient in this. The patient's not been engaged at all. It's completely stuff that we do to them. So we're just making the same mistakes. And then they had nothing to address dementia and delirium. So I think the intervention was just not the right one. So this is my back of the envelope Cochrane review for 2015. And basically it shows that a graph now has that triangle, not triangle, rhomboid or whatever it is, going across the line. So we are going to see this thing where if they do another Cochrane review in the same way they've done, that what we do for FRAMP is going to be non-evidence based. Okay, but never fear. For every complex problem has a simple solution. And by the way, that was going to be a video of red socks. So red socks are not the simple solution, please. I've just got to hammer that one in. Even though they get a lot of attention. You know, one of the trials had fluorescent toilet seats. That got a lot of attention too. But these things, we need to avoid making it simple. So there is no simple solution, but the solutions that I can propose are, one, is that what we're doing is good. Whatever Northern's doing is working, because they've shown over a 10-year period that they're reducing fractures. So why do you need a randomised controlled trial to then test it and say it doesn't work? Do you know what I mean? So let's just go back to the basics and say, hey, wait a second. This started from looking at clinical care and saying what you're doing is working. So that's one way of ignoring it. The other way is to just step back and say, well, what's our Western Australian data? And this is data from 2002 to 2011, and it shows the number of falls incidents over that period of time. So, and we're seeing a fairly steady reduction since about 2002. Obviously that year before was a reporting issue. We'll never have this graph again because now we've moved towards electronic reporting. It's going to be different numbers, so it's jumped up a bit. But what we're doing in Western Australia is working too. If you look at this, is across all metropolitan and rural sites, everything added together. The flaws of meta-analysis as well is when you look at the Cochrane, they've actually only got 4 studies in them, and they're quite different studies. One was in orthogeriatrics. That's quite different to the general medical ward. We need the bigger picture. It's actually not about falls prevention. I mean, although I go on about falls prevention, I'm not actually about falls prevention per se. What I'm really about, or what we're really about, is about good patient care, and that's what motivates clinicians, and that's why that this stuff is of interest. And that we need holistic care for syndromes, not bundles of care that we give to people. And that clinical judgment is going to always be at the heart of good clinical care. And the horse is bolted. The FRAMP is now our baseline care, and this trial. So this is now I'm going to make you feel better. So even if that scenario did happen where the guidelines say it no longer works, I want you to feel relaxed, knowing that that actually doesn't matter. That's just a research conclusion. At a clinical conclusion, we can say, well, actually, we need to do this care. It's been effective when we've done it across the whole system. What we need to do is just continue to tweak it, make it better. And Sue and the groups in the community practice have done an incredible job on the FRAMP. We need to add on to this, and that's where the education comes in. And then we need to keep it interesting, which is where the education and the kind of April Fools and just thinking of falls not as something boring, but something that's about good patient care, something that cuts across everything, something that's relevant across the population, because it is. Because we've all got older people, we'll be older people ourselves, and there's stuff you can do even now at our age to make yourself more robust and healthy and avoid these kind of outcomes. Okay, and of course this is where the money's at. Anne-Marie Hill is an amazing person that we're really privileged to have in Western Australia, who can give us this type of direction. And we avoid red herrings. Okay, I've spoken for long enough. If there's any questions, please ask. Is anyone there? That kind of moment when you realise everyone's talking to myself.
Okay, we'll go on to... is there anybody on VC? Did you want to ask any questions at all? Is that a negatory? Yep. Anybody in the room?
Just one simple question. You started at the start with the data. That's 8-9. Is there no? They've done no more of those studies since then?
They get released annually.
Okay.
But it's just the same document every time now.
Yeah.
So yeah, that was the one. That was the only one that they'd done that actually had states broken down. Because before that they couldn't do that. That's like dirty word, you know.
Yeah.
We present the national data. That's our agenda. We don't look at individual data.
Right.
That's your state to do. So that was the first time that it had ever been done,
Right.
and I've never seen it done since.
Oh, I see.
Yeah, but you know the trends. The more up to date data hasn't changed, and also it takes years for the stuff to come out. So they do it 2008. It might get released 2012. So even though it looks old, it's actually the most up to date you can get. But yeah. The other way to do it is just to say, well, that's good. Let's just keep showing that graph for as long as we can, in case it changes. But luckily, it hasn't yet. Sue will probably fire me when it does.
It is difficult to get the up-to-date data from
National
the
data.
system. Yeah, it is difficult.
And it's very broad brushstroke stuff too. It's like, what does that mean for the individual person? It's a little bit. It's incredibly broad brushstroke, but still, it's the best we've got. Well, thanks very much for coming and hearing me on my soapbox.
We'll do it all again in another half an hour. Thank you.
Yeah. Thanks, guys.
Thanks, Nick. Thank you.